The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our topic today is From Mutation to Treatment, Understanding the Impact of IDH Inhibitors. Thank you to today's webinar sponsor, IMVAX, for their support of this program. My name is Umbreen Mon, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. John Groot is the Division Chief of Neuro-oncology at UCSF. He has brought new therapies from the lab into the clinic to treat patients with brain tumors. In particular, he has contributed to the development of glioblastoma treatments and has a special interest in using blood analyses, imaging studies, and other indirect biomarkers to evaluate the efficacy of novel therapies. We're really excited to have you with us, Dr. de Groot. You may now begin your presentation.
Well, good morning or good afternoon, depending on where you are. It's really, truly an honor to be here today and I really appreciate the American Brain Tumor Association for inviting me to give this presentation today, and particularly to Ralph DeVito and all of his leadership of the ABTA, as well as Umbreen and Mindy for their support in getting this up on the screen today. So our learning objectives here are really to understand what IDH mutant tumors are and how they're diagnosed, learn how these mutations would potentially influence treatment decisions, and then recognize the role of these new IDH inhibitors that we have to improve patient outcomes. These are my disclosures. Okay, so the outline of my talk, I'm going to try and keep this to around 45 minutes or so, is to give an overview and definitions of IDH mutant glioma, including low-grade gliomas, talk about the goals of therapy. And I think in that context, it's important to kind of understand what the historical perspectives are and what the toxicities of those treatments are. And then talk about why it's so important that we now have a new IDH inhibitors, and give you some updates on the use of those treatments for patients with IDH mutant glioma, and then summarize and provide some future directions. So this is kind of a busy slide, but this is really kind of describing a little bit of historical data around the World Health Organization classification of tumors of the central nervous system. And really, we're just focusing on diffuse gliomas. So those are sort of not circumscribed, sort of more diffusely infiltrating tumors. And I think, we use the word IDH now quite a bit. We're all very comfortable with that. But it's important to keep in mind that IDH mutations weren't discovered until, and their role in glioma weren't discovered until about 2009. And so it took a while to sort of incorporate that into our classification system. So it wasn't until 2016 that IDH mutation and its role in classification was actually recognized. And then in 2021, with an additional 5 years, we had a much better understanding of the role of IDH and its ability to subset different types of diagnoses. And it really has given us sort of a way of better classifying these types of tumors. So with the full integration, we separate diffuse glioma into 3 groups, and we're really focusing here on adult type diffuse glioma. There are other pediatric types that we won't discuss today, but then there are 3 distinct subtypes of these diffuse gliomas. And there's the astrocytoma, IDH mutant. There's oligodendroglioma, which is IDH mutant and 1p19q co-deleted. And then the third one, which we're not going to talk about, is glioblastoma. But it's important to recognize that those tumors are what we call IDH wild type, meaning that they do not have a mutation. If we're talking about astrocytoma, there are 3 potential grades, grade 2, 3, and 4. Whereas oligodendroglioma really are only classified as grade 2 or grade 3 tumors. If you look at the distribution of these diffuse gliomas, going back a couple of years, really, we're looking at about 50% of those tumors diagnosed in North America are glioblastoma. And then around 10% are the diffuse astrocytoma, and a smaller percentage, half of that, maybe around 5%, are the oligodendroglioma types of tumors. Again, these tumors can be classified as grade 2s, 3s, or 4 in the astrocytoma group, sort of relatively evenly distributed there. And then more commonly, grade 2 oligodendrogliomas are diagnosed than compared to grade 3. The median age at diagnosis for patients is approximately 40 years old for those patients diagnosed with the grade 2 diffuse glioma. And both astrocytomas and oligodendrogliomas are more common in men than women, also true for glioblastoma. It's important to kind of note that, this is a pretty rare type of tumor, IDH mutant gliomas. And in North America, it's just a few thousand people diagnosed with these IDH mutant tumors every year. So what is the impact of this classification on patient overall survival? I think these lines are over just a short period of time for a couple of years, but it kind of gives a more of a general trend of what you would expect to see. So the bottom line, which is with the shortest survival, is what we see with patients with glioblastoma, WHO grade 4. This line in the middle here, this sort of purplish line, is the astrocytoma IDH mutant grade 4. So this is the most aggressive of the IDH mutant astrocytoma tumors. And then the remainder of the tumor types have a much slower trajectory, are slower growing, less aggressive. And of those, the oligodendrogliomas are sort of the top line up at the very top, showing that just over a couple of years. Now, granted, this is only a 2-year chart, and for some of these tumors, we're measuring some median survival on the order of a decade or two. So this is just kind of a small snapshot of what that trajectory looks like. So what are IDH mutations and also 1p19q codeletions? So the first thing really to focus on is IDH. And IDH stands for isocitrate dehydrogenase. This is an enzyme that's in the citric acid cycle, a metabolic cycle that's present in all cells. And these IDH these IDH enzymes are really important for normal cellular function, for the normal generation of energy. But what can happen is if there is a mutation in either IDH1 or IDH2, which can happen, most of the mutations are in IDH1, but these lead to sort of an overactivity of the enzyme. And that leads to a greater production of this metabolite called 2HG, which is 2-hydroxyglutarate. So these IDH mutations lead to the elevation of 2HG, and what we call 2HG is a quote unquote oncometabolite. So what is an oncometabolite? Essentially, this is a molecule in the cells that's actually promoting tumor growth, and it does it in a variety of different ways. But we now know that having too much hydroxyglutarate in the cell can lead to more tumor-like behavior. So mutations of IDH1 or IDH2 occur in about 70 to 80% of these grade 2 and grade 3 adult diffuse type glioma. The most common mutation, IDH1, this is getting into a lot of detail here, but is a mutation called R132H. And essentially what this is referring to is the substitution of an amino acid in the protein at this 132 site. So this R132H mutation is the only mutation in IDH1 or IDH2 that can be detected by immunohistochemistry. So the IHC is what the pathologist would do when they take a slice of the tumor tissue and they apply an antibody stain to that section and be able to actually visualize this mutated protein. And so the turnaround for doing something like this is just 2 to 3 days, so it can be very quick. But there are several other IDH mutations, so IDH2 mutation, and then there are other IDH1 mutations, R132C, R132G, various other ones that are less common, but we're not able to actually use the staining to detect them. So this actually requires sequencing of the gene. So this is why it's really important when we're seeing patients that are particularly younger. Again, you think about the age of 40 as the average age of diagnosis, wanting to make sure that even if the stain is negative, that doesn't necessarily mean that there's not an IDH1 or IDH2 mutation. It is important to note, of course, that as we saw on those curves, the survival curves, IDH mutations are associated with a much better prognosis and also a better response to the treatment. And we'll talk a little bit about what those treatment options are, but in general, that's a correct statement. And then when we're trying to distinguish between astrocytoma and oligodendroglioma, it's a little bit more complicated, but we have genetic testing where we're actually looking for the loss of the arm of 2 different chromosomes. And this is one of the best tests that we have for looking at this. So we're looking for the loss of 1p and 19q. We call it a co-deletion. And it can be detected by multiple different assays. There is this FISH is fluorescence in situ hybridization. This is, again, more like a stain, being able to look at it on the slide. But then there are other more complicated genetic assays, such as like next generation sequencing, which was what we would do to look for an IDH mutation. And then we really have to have this full co-deletion of this 1p19q in a patient in a tumor that has an IDH mutation. So really requires the IDH mutation and that 1p19q co-deletion to be given the diagnosis of oligodendroglioma. So again, going to sort of a schema of sort of how we might be thinking about this, how the pathologist might be thinking about this to sort of make that final diagnosis. So if a patient has a diffuse glioma and the pathologist is looking at it on the microscope, one of the very first things is thinking about that. Is it IDH mutated or not? If it's not IDH mutated, then it's a wild type tumor. And again, that's where the glioblastoma is more likely to occur. But if it is mutated, then you're really trying to just differentiate between an oligo and an astro. And if it has this 1p19q co-deletion, then it falls into the oligodendroglioma category. And then the pathologist might look at this under the tissue under the microscope and see if there's necrosis of dead dying cells, or if there's microvascular proliferation, which occurs when a tumor is rapidly growing and trying to bring in blood supply to help support its growth. And if there is none of that, it looks more low grade, then that would be a grade 2. If not, it becomes a grade 3. On the astrocytoma side, again, pathologists looking for this necrosis or microvascular proliferation. If they see that, then it's a more aggressive World Health Organization grade 4 astrocytoma. If it's not seen, then one of the next important steps is to look and see if there's a loss of this gene called CDKN2A/B. It's kind of a long name, but this is a part of the next generation sequencing panel that we do on tumors. And if it is lost, then that automatically upgrades it to a World Health Organization grade 4. So if that's not the case, if it's not there, and it looks like there's very, very low amount of cell division on the slide, then that becomes a grade 2. And then if there is some cell division that the pathologist can see, then it would be more likely to be a grade 3. So complicated, but IDH mutation testing is one of the very first key important steps, and then looking to see whether genetically it fits into more of the oligo category or the astrocytoma category. And then after that, looking at whether it's grade 2 or 3 in oligos or grade 2, 3, or 4 in astrocytoma. So this is some imaging and pathology. So it makes a couple of important points looking at this at the scan. So one is just how we would look at a patient's MRI and say, well, that looks like a diffuse glioma. And it's really because you don't see a well-circumscribed mass. You see much more of an infiltration where you can't really detect the precise border of where the tumor starts and ends. And you see that both in grade 2 and grade 3 IDH mutant astrocytoma. And then if you look at the tissue section, so this is what we call an H&E, so it's just a basic stain looking at kind of the architecture of the tissue and looking at the cell types. You can see this does not, it has more cells than you would normally see in normal brain, but it's not very densely filled with tumor. And then in the bottom tissue section, you see many, many more cells. So you could see how we make the different diagnosis between a grade 2 and a grade 3. And then as I mentioned before, if you see what we call mitotic activity, so you actually can see cells that are in the process of dividing, so one cell becoming 2. If you see that, that's more likely to be a grade 3 tumor, and you can see some of that happening here on the images. And then if you look at oligodendroglioma, glioma, the morphology of the tumor cells is really different. And fortunately, we have pathologists doing this, but the grade 2 histology here has what we call a fried egg appearance, where you can see the nucleus as being very dense, and then you see a white ring around the outside of that. That is actually an artifact of the staining process, but it's really very closely affiliated with having an oligodendroglioma. And so it's pretty obvious to see just on the pathology. In the grade 3, again, one of the big differences is just the total number of tumor cells that you see on the section. And then, as I mentioned before, you can see some tumor cells that are actually in the process of dividing. So that what we call mitotic activity, and also some vascular proliferation. So that would upgrade that tumor to a grade 3. This is, again, looking at the imaging with a little bit more detail. So non-enhancing tumors, but you can have non-enhancing tumors that are also IDH wild type, as you see here, or in IDH mutant astrocytoma. Again, you can see a little less edema and not enhancing after giving IV contrast. One of the things that we're really trying to figure out how to do is to be able to look at a patient's MRI scan and automatically tell whether or not it's IDH mutant or not. There's a lot of work going on all over the country, actually all over the world, to try and figure out how to do that better. There is one sign that we call the T2 flare mismatch. And you can see sort of in this upper panel on the right-hand side here, in the IDH wild type group, you can see that the brightness looks about the same, both on the T2 sequence and on the flare sequence. Whereas this upper image here, you can see on the T2 sequence, it's very, very bright all the way across. But on the flare sequence, it looks a little less bright, looks a little bit more similar to the normal brain tissue. That's the T2 flare mismatch. And on this column here, we know that these tumors are IDH mutant. The problem with this, of course, is that the sensitivity and specificity is not great. So there could definitely be some false negatives in there and misdiagnosing patients. So we don't use this. We definitely really rely on having tumor tissue and doing the staining and the sequencing for the IDH mutation. So our goals of treatment, once we know our diagnosis, are obviously to slow the progression of the tumor, increase patient survival. And I think it's important to think about also the fact that we're trying to reduce the symptoms related to tumor progression. And I think, we frequently think about symptoms related to our treatments, which is another thing that we're going to talk about today. But stopping the tumor from growing also prevents the tumor from producing, a decline in neurologic function, a decline in cognitive function, and all of those things as well. And then hopefully to delay or prevent the transformation to a higher grade tumor. So I wanted to just go sort of take a step back in time a little bit to talk a little bit about where our, our prior, before, 2 years ago, where our prior treatment paradigm came from. And this is sort of one of a couple of important studies that looked at the treatment of low-grade glioma. Now, this is in 1998 is when this study was sort of initiated. And of course, that was a full decade before IDH mutations were even discovered. So it's not 100% accurate with our current World Health Organization classification system, but it provides a lot of really important data in terms of how we think about and how we thought about treating patients with grade 2 glioma. So in those times, we used, based on some previous studies to that, some good data suggesting that if younger patients and patients whose tumors were completely resected, what we call a gross total resection, tended to be lower risk of progressing. And I think we still think about that as a group of patients where we would just observe. But in those patients who are high risk, which at the time we were calling older patients older than 40, or who had subtotal resection or just a biopsy, are at high risk of progression. And so those patients on this study were randomized to radiation alone or radiation followed by chemotherapy. And the chemotherapy used at the time was PCV, which stands for procarbazine, CCNU, and vincristine. It's a 3-drug regimen that has been around for a long time and shown to be quite effective. And so what the study showed, and again, this is for patients right when they were diagnosed, were randomized to, either observation if they were young and had a good resection, or radiation or radiation plus PCV. And what this data shows us here is that those patients who got radiation followed by chemotherapy did much better, and almost a doubling of survival if you look at all of the grade 2 glioma patients. And this is statistically significant. When we talk about significance, we talk about a p-value of 0.05 or better. So this is less than 0.05. So this is a really important and a very effective therapy for patients with grade 2 glioma. If you break it down into patients with oligodendroglioma versus astrocytoma, again, in the oligodendroglioma group, had a really significant improvement in patient survival for those patients who got radiation plus the PCV chemotherapy. In grade 2 astrocytoma, this curve separated, but was not what we call statistically significant. But one question is whether or not there were enough patients to be evaluated to really make that determination. I think we still don't know full answer to that. But I think what we all think about, and particularly as I've spent the last 2 decades in this field, is that not only can tumors cause toxicity, but our therapies can as well. And so over time, thinking about what is the impact of radiation and chemotherapy on patients is a really important consideration when we talk about how we're going to treat patients. Some of the things that we see very commonly are radiation necrosis, which can also cause really quite significant neurologic impairment. We see hemorrhage over time. We know that there can be what we call a vasculopathy. The vasculature becomes abnormal, and it can close off, or it can spontaneously bust and cause either a hemorrhage or a stroke. Some of our treatments, such as temozolomide, can cause hypermutation, which could potentially change the biology of the tumor. And then we also know that some of these therapies can cause neurocognitive changes. So a recent study that I put down here looked at sort of health-related quality of life and thinking about the impact of treatment on cognitive function, on sort of emotional state, their role in society and the family, social functioning, and also fatigue and insomnia. And all of these were very common. And looking at 12-month intervals over 10 years saw a steady decrement in all of those different aspects of quality of life. So very, very clearly, these treatments have a major impact on patients' lives. So this kind of brings us to our current era. So as I mentioned with that study 9802, where patients that were considered low risk, where it could undergo this period of observation, this sort of presented a great opportunity to look at new therapies, and in particular, this new group of drugs called IDH inhibitors. So if we kind of think about a newly diagnosed patient with a grade 2 glioma, oligodendroglioma, or astrocytoma, really two choices, follow the RTOG 9802 study and just go straight into radiation followed by chemotherapy, or observation. And there's a lot of factors that go into why a physician might recommend one or the other, but observation in many of these patients is very appropriate. And so that was where we were able to sort of insert a new opportunity. And this came about through really some amazing work done by a company called Agios and then Servier, and many really talented investigators in this particular study led by Dr. Ingo Mellinghoff at Memorial Sloan Kettering in New York. And this is the Indigo study. So this is a study for IDH mutated grade 2 oligo or astro. Again, the study was started a while ago, so it's still using those 2016 criteria. Patients could only have had prior surgery. Now, they could have more than one surgery, but they had to have been at least 1 year out from surgery and less than 5 years from surgery. They had to have something to measure. So non-enhancing disease, we call it measurable disease, which really is having something that's at least 1 centimeter by 1 centimeter in diameter. And then not in need of some kind of immediate treatment for some other reason, so something concerning on the investigator side. So patients were randomized and they were blinded. So physicians didn't know the treatment and the patients didn't know the treatment. And they were randomized either to the Vorasidenib once daily on 28-day cycles or to a placebo. And patients were grouped sort of based on whether they were oligo or astro, so 1p19q status, and then the baseline tumor size. And then importantly, those patients that were in the placebo group, if they progressed, were allowed to cross over and receive the active treatment. So it's really an important aspect of the study. So these are sort of what we call the baseline patient characteristics. There's a lot of numbers here. I don't think we really need to go into a lot of detail, but more. So the median age was 40. So that's right on target with what we know to be the most common. More males than females. Most of the patients were doing very well physically and mentally. They all were around 2 to 2.5 years from the time of their last surgery. And then almost half of oligodendroglioma and half astrocytomas enrolled into the trial. And this is the sort of the first primary endpoint for the study, which is progression-free survival. So these are patients who are still alive and have not had progression of the tumor on MRI scan. And you can see that here in the blue line, the patients who got the IDH inhibitor Vorasidenib had a much longer median progression-free survival compared to those on the placebo, so 27 months versus 11. And this was incredibly significant. So we talked about one of those other studies of, 0.003. You can see how many zeros there are here on this and just how incredibly significant these results are. Now, this is also a little bit confusing. I'll just try and explain it really at a very basic level. But this is looking at different subgroups of patients, number of prior surgeries, age, sex, all of those different things. And this dotted line that you see here comes down to 1. And anything to the left of that demonstrates that Vorasidenib was better than placebo. And so you can see all of these squares and lines were on the left side of 1, suggesting that Vorasidenib was better than placebo. And it didn't matter whether you were 18 to 40 or older than 40. Didn't matter whether you were male or female. The tumor or the location of the tumor didn't matter, or the number of years from when you had surgery didn't matter. And of course, it didn't matter whether you were co-deleted or not co-deleted, whether you're an oligo or an astro. So really impactful across all of the different subgroups. And the second outcome of the study, the second primary endpoint was the time to next intervention. So this is basically just a way of saying time until a patient needs surgery or radiation or chemo or some other kind of treatment because of tumor progression. And you can see that almost none of the patients in oligodendroglioma needed any additional treatment. They just continued on the Vorasidenib. And then in astrocytoma, also very, very significantly different. Those patients with astrocytoma had a much longer time until they needed another therapy compared to those patients who got placebo. So how easy is it to take this medication? This is something that patients are taking every day, once a day, on 28-day cycles for years. And this is a table showing treatment emergent adverse events. So we call them TEAE. It's what are the side effects and how often do you see that in the two different groups? And so a couple of key points is there was a little bit more treatment interruption due to side effects in the Vorasidenib group compared to placebo. Some of the patients, around 10% of patients, needed to have their dose reduced because of some side effects, which was also more common in the Vorasidenib group than in the placebo group, but also very low rates of discontinuation, much less than 5%. But what were those side effects, and how impactful was that to patients' quality of life? The most common side effect that was really much more common in the Vorasidenib group than in the placebo group was the effect on liver enzymes. And so you can see increased in ALT and AST and this enzyme called GGT. And you see that in much higher levels, really of any grade than you would see it in the placebo. But if you look across all the other potential side effects, so fatigue was the same between the two groups, headache the same, diarrhea a little bit more common in the Vorasidenib group, but not by much. Similar amounts of nausea between the two groups, same amount of dizziness, et cetera. So I would say very, very well tolerated over long periods of time. This is the FDA approval. So this was incredible. In August of 2024, we had the FDA approval for Vorasidenib, and the indication is adult and pediatric patients 12 years of age and older with grade 2 astrocytoma or oligodendroglioma with an IDH1 or 2 mutation following surgery, including biopsy, subtotal resection, or gross total resection. And just importantly, it does target both IDH1 and 2, which is critical. Were some in development that only targeted IDH1. It definitely decreases the production of this oncometabolite 2-HG, and it gets into the brain very well. So There are some really important endpoints that this clinical trial will help us to answer. And, I'm going to just sort of read over these briefly, but they'll show us, what are the response rates, how much of those tumors actually shrink. And if they don't shrink, another thing that can happen is that you can actually slow the rate of growth. So maybe it was growing very quickly, and then with this therapy, actually the growth rate actually started to slow down. So it actually becomes more stable over long periods of time. Overall survival is something that's important. And then how long does this work and hold that response? Other endpoints such as quality of life, neurocognitive function, and the impact of these drugs on seizure activity are all really important. And then some of the other things that we would like to know is, what are some of the molecular predictors of response and resistance? So, are there other things in the tumor that might tell us whether or not patients' tumors might get smaller? Which patient populations benefit? Are those that are stable, or are those that have actually progressing of their tumor? And does starting at 1 year versus 5 years change that long-term outcome? Okay, is it okay to wait 3 or 4 years before starting, or should we start right away? And does tumor size also, do larger tumors cause, have a worse outcome compared to smaller ones? Things that we all need to learn to know. And I think the other really important point about these drugs is about Vorasidenib is that so far we don't have strong evidence that it is effective in enhancing tumors. And this is actually, it's a different patient population. This is not newly diagnosed, this is recurrent patients. But you can see in those patients who have enhancing tumors, the median duration of treatment was just a few months before there was evidence of tumor progression compared to the non-enhancing ones. So clearly this amount of the enhancement that we see on the MRI scan might give us an indication that maybe there's something about the tumor biology where inhibiting IDH in and of itself isn't enough. So some really important follow-up is there an impact of Vorasidenib on tumor biology? And of course, as I mentioned, long-term patient outcome. It's going to be difficult to compare the results from the Indigo trial with that other study that I showed you about from 9802, because those patients were treated right at the time of diagnosis, whereas the study, patients were treated after some period of observation. Is there any kind of risk with delaying more definitive therapy with radiation and chemotherapy? We don't think so, but we actually don't have an answer to that yet. Could inhibiting this molecule, this enzyme, lead to changes in the aggressiveness of the tumor? And then really, what is the impact of implementing these IDH inhibitors early on, and what does it do for overall survival? That 9802 trial that I showed took over 15 years for us to get the results from that study. And so it's going to be a while before we really have a good understanding of how much of an impact these treatments are going to have on longer term outcome. We really want to know what are the mechanisms of on-treatment resistance. So, those patients who came, off of the study with off of the drug earlier, what was the mechanism of resistance to the inhibition of IDH? Really important as we're starting to think about combination therapies. And there are some studies that are ongoing and being developed to see what could we do to enhance the efficacy of these IDH inhibitors, either in just grade 2 tumors or even in higher grade IDH mutant glioma. And currently there's a clinical trial in recurrent enhancing glioma, looking at Vorasidenib plus pembrolizumab, also called Keytruda, so the checkpoint inhibitor, to see if that might be more effective in the subgroup of patients. So one thing that I think might be helpful to discuss is just sort of what should you ask your care team? One, of course, is, does my tumor have an IDH mutation, and how was this confirmed? We talked about staining versus next generation sequencing. How effective do we think Vorasidenib will be in treating my specific type of IDH mutant tumor? We talked a little bit about common side effects, but how would those be managed is an important thing to discuss. Are there long-term risks associated with taking an IDH inhibitor? In young adults, thinking about fertility and not being able to be on an IDH inhibitor during that time period is an important consideration. What are alternative treatment options? And then how would those compare, both in terms of toxicity, short-term and long-term toxicity, and also an outcome? And are there any clinical trials that are enrolling patients with my type of IDH mutant tumor? All important things, I think, to ask. So in summary, newly diagnosed IDH mutant low-grade glioma, unfortunately, remains incurable, but we have some really great new therapies that can change the long-term trajectory potentially. Current standards of care are effective, but obviously, as we talked about, can lead to some long-term toxicities. The IDH1/2 inhibitor Vorasidenib significantly delayed progression-free survival, time to next intervention in resection-only grade 2 oligo and astro. It's really important. And the impact of IDH inhibition on patient overall survival is currently unknown, but hopefully we'll know that in some time from now. The optimal timing is still also not really known in terms of the sequencing of an IDH inhibitor with other therapies such as radiation and chemotherapy. So something important for us to determine the optimal timing there. And then we really need to create new studies to look at IDH inhibition plus other therapies to improve the outcomes of patients with either enhancing or grade 3 and 4 IDH mutant glioma. So with that, I'd just like to thank you all again for attending and for listening to my talk. And I'm happy to take questions. And again, thank you to the ABTA.
Thank you so much, Dr. DeGroot. We're going to jump right in with the questions because we have quite a few. Just as a reminder for anyone, if you do want to submit a question, please click the Q&A button on the bottom of your screen, type and submit it, and we'll try to get through as many as we can. So one question we have here from someone from Sydney, Australia, really cool to see you online, is talking about one of the goals that you mentioned about treatment being to help prevent transformation of the tumor to a higher grade. Are there any new studies about this, about preventing tumor progression that you can share with our audience, or maybe provide some resources that they can go to learn more about that?
That is a great question. This is something that's very hard to study in people. I think there is actually a little bit of data out of a study of in Massachusetts General Hospital. I believe it's Dan Cahill did the work, and I think there could be subtypes of these tumors, of these IDH mutant tumors, that might where IDH inhibition actually might be able to change sort of that trajectory. And I think it's just really early to truly understand if that's the case. But yeah, I'm happy to point in the direction of that study if that would be helpful.
Thank you so much. We will be sending out a resource handout post-webinar, so we'd be happy to include that in there for anyone who's interested in learning more. Another question we have is asking, do IDH inhibitors increase glutamate production? And can you maybe also preface that with the impact of glutamate on maybe tumor progression and growth?
This takes me back. I used to study glutamate when I was a neurology resident at Johns Hopkins, glutamate and brain tumors specifically. I think there was a lot of interest and a lot of thought that glutamate in and of itself, through either excitotoxicity, so sort of stimulating the neuronal milieu within and surrounding the tumor could potentially promote tumor growth. And there's also was the thought that maybe excessive glutamate actually kills normal cells and actually allows and creates an opportunity for tumors to spread and infiltrate greater. Most of that work really has been done in glioma and in glioblastoma. There is some more recent work that's happening actually at some places here in California and other places across the world looking at that question. I think it's still a theoretical possibility. How do you inhibit that? I think is a much harder question. So, I don't think that there's any question that it's playing a role. I think one of the questions is how big of a role and how can you shut it down? It's a very challenging thing to do because glutamate is incredibly abundant in the brain.
Thank you so much for explaining that. We have another question here from a patient. This patient has already undergone treatment for an IDH mutant anaplastic astrocytoma in 2021. They got treatment, chemo. They're now 3 years post-treatment. For a patient like this, should they be asking their neuro-oncologist about going on Vorasidenib? Is that an option for them or something they should consider?
Right. So the original or the current indication, is really for IDH mutant glioma. The data that we have from the Indigo is really primarily for patients that were diagnosed with a grade 2 and had not received any additional treatment. That being said, I think this is a question that we all have, which is, after you've had treatment, the disease burden is what we, it's called low disease burden, where, a lot of the tumor cells are either resected or killed with radiation or chemotherapy. Could there be a role in using an IDH inhibitor to delay recurrence? And unfortunately, we don't have any evidence that might be the case, but I think it's an important thing to talk to your providers about.
Thank you so much for that answer. Another question we have here is asking about, I believe this is for the Vorasidenib trial. Do you know if these patients are being followed post-trial? So will there be data on, long-term impacts, maybe past 30 months of being on the treatment?
Absolutely. Yeah. So patients will be followed forever. And I think it's such an important question because, the data that we have, I think, I don't think I mentioned this, but the study, they expected the study to go longer than it actually did. But the results were so profound that they were able to stop the trial early because it had such a major impact on outcome. And so, I think they were planning to keep going for several more years. So it's really exciting in that sense. But that long-term follow-up is really critical for this study and actually for all clinical trials to understand the full impact on long-term outcome.
Thank you so much. We have a question here about wait and watch. And again, this is for Vorasidenib. Could Vorasidenib be used during the wait and watch period as a preventative measure for disease progression?
Right. So that would be, so in that observation period, and I just have to say, I know my own personal practice and others that I work with, not all patients who undergo surgery immediately go onto Vorasidenib. I think there is still a potential role for observation, and it depends on the patient and what type of tumor they have, and obviously what the grade is. But I think that is still one of the challenges that I face as a physician when I'm looking at a patient, talking to a patient. Should I use it now? Should I use Vorasidenib now, or should I wait a year, or could I wait a couple of years? Like that And unfortunately, again, we don't know exactly what the right answer is.
Sorry, thank you. Another question we have here is asking, how long can a patient stay on an IDH inhibitor?
As far as I know, for for years. I mean, we're still sort of very early, just in terms of the experience. The original clinical trials were published, 3 or 4 years ago. So we do have some patients that have been on it for, over 5 and over 6, 7 years. But that's kind of the extent of our experience in the field. So we're expecting that patients can stay on it, potentially forever. But we don't have those yet.
Thank you. Is there any hereditary link with the IDH mutation?
Not that we're aware of, no. We don't really know what causes the IDH mutation, or even when that IDH mutation occurs. Is it present at birth? And, do we acquire it later in life? We don't know of any factors that would increase our risk of developing that mutation. But those are a lot of unknown questions about them.
We have a question here asking about the differentiation of methylated versus unmethylated. Can you explain what that means and the importance of that?
Sure. So didn't really talk about that. So when we talk about methylated, we're usually referring to MGMT, methylguanine methyltransferase, which is a DNA repair enzyme. And that is when this enzyme is, it's actually the promoter that's methylated. So the part that kind of turns the gene on and off. So if the tumor is methylated, then none of that repair enzyme is made, and therefore things like radiation chemotherapy that damage DNA, that can't be repaired. And so then tumors tend to die, as opposed to be able to repair the DNA and escape the treatments. So in these lower grade glioma and oligo and astro, they tend to have MGMT promoter methylation. And that just, suggests that they're more likely to respond to things like radiation and chemotherapy.
Thank you so much for providing that understanding of methylation. We have a question here talking about the IDH mutations. You mentioned that, IDH mutant tumors, they can help to, or we see that there's a slower progression and it can help with improved outcomes. So this attendee here is asking, why then is IDH inhibition beneficial if the IDH mutation seems to be a positive finding?
Right. So what we think is that IDH mutation is one of the very first events that occurs that makes this precursor cell normal to abnormal. We call them truncal mutations, which is essentially like you were thinking about the trunk of a tree, sort of what is at its key element that's actually driving this to become a tumor. And so one of the exciting things about IDH inhibitors is that it is targeting a truncal mutation. Once the tree grows and you have multiple branches, targeting these secondary alterations may not have as big an impact. And so having this inhibitor that inhibits this early event is most likely to have the greatest impact on the progression and hopefully transformation of these kinds of tumors.
Thank you. We have another question here asking if you can explain what the difference is or how Vorasidenib compares to Evosidenib in terms of efficacy, disease progression, and side effects.
Sure. They are very similar. But Ivosidenib was approved for leukemia, for IDH mutant leukemia. And so it was not actually created to have, optimal blood-brain barrier penetration. It does get into the brain, but vorasidenib gets into the brain better. And that was sort of one of the reasons I think, why vorasidenib went into a randomized phase 3 trial for IDH mutant glioma, as opposed to doing that with ivosidenib. So we don't have phase 3 data with ivosidenib, and we don't have a comparison really between the two, looking at long-term outcomes and progression-free survival and those kind of data. So, for my patients, I'm really prioritizing vorasidenib because I know that it gets into the brain really well, and we have this really strong phase 3 data.
Thank you so much. And I was kind of backtracking back to IDH mutations and how they're diagnosed. Can you remind us again of what tests are done to diagnose an IDH mutation? And are these tests that are done to all patients, or do patients have to request for these type of genetic mapping to be done?
Yeah, so currently the pathologic diagnosis of diffuse glioma requires both, the pathologist looking at it and describing the tissue under the microscope and the molecular testing. So that should automatically be done. The two ways of discovering IDH mutation are, as I was mentioning with the stain, the immunohistochemistry, or IHC, which only detects the R132H mutation, which is the most common, but there are others that can only be identified with next generation sequencing. So this should not be something that you would have to ask, the pathologist or your oncologist to order for you, but I think it's helpful to know what those results are and how they were determined. And obviously a lot of the pathologists, if they have questions, they get consults from some of the world's most experienced neuropathologists.
Thank you so much for that answer. Another question about the IDH mutation. Can a patient ever lose the IDH mutation?
Great question. I don't think I've ever seen a patient lose an IDH mutation. I have heard of a patient who was on an IDH inhibitor who developed an IDH2 mutation instead of an IDH1 mutation, but I think that's probably very, very, very rare.
We have, and I think this might be our last question that we have time for. I'll try to see if we can squeeze in one more. But this question here is asking, and I believe they're asking specifically for vorasidenib, but they're asking, is it possible to have a child while you're on treatment? Or do you know if there's any quality of life or impact of that for a patient who's considering starting a family or expanding a family?
Yeah, so it's recommended not to conceive, while on vorasidenib. Yeah, I think it's in the package insert.
All right, thank you. And then I think we have time for just one last question. And this should be a quick one for you to be able to answer. Can you explain what is the difference between voranigo and vorasidenib?
I'm not sure I know.
Okay.
I guess it's generic versus brand. Yeah.
All right. Thank you so much. I know we've had so many questions, but Dr. de Groot, I appreciate you taking the time to go through all of these. I hope it was beneficial for attendees to get to hear this. And again, I just want to thank you, Dr. de Groot, for taking the time to present this amazing webinar and sharing your insight and expertise with our attendees today.
My pleasure. Thank you.
I also want to thank our webinar sponsor, IMVAX, for their support of this program. And of course, a special thank you to each and every one of our attendees for joining us online and sharing your questions. We hope that you found this webinar to be beneficial. We encourage you to take a few minutes to complete our webinar survey by scanning the QR code on the screen or going to the link on the screen. Your feedback is important to us as we plan for future programs. You'll also be receiving a link to the survey along with the webinar recording and a follow-up email message over the next few days. If you are looking for more opportunities to have your questions answered, Dr. John DeGroot will be joining us this Monday, February 3rd through Friday, February 7th on ABTA's online support community Connections, hosting an Ask the Expert all about IDH mutations and inhibitors. This event, like I mentioned, will be taking place on our online support community Connections that you can access by going to abta.inspire.com. You'll be able to post your questions and Dr. DeGroot will be answering them throughout the week. If you're looking for more educational content like this webinar, please join our next webinar, New Horizons in External Beam Radiation for Brain Tumors, taking place February 19th, presented by Dr. Joseph Bovey from ThetaCare. You can register by going to bit.ly/FebWeb2025. For more information about ABTA's programs, events, and services, please visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. This now concludes our webinar. Thank you again for joining us and enjoy the rest of your day.